I'm Julie with another episode of Take One Patient. I'm very excited because I'm here with Sean Wood. He is the VP of Mid-South Transitional Medicine or Medical Group, excuse me. And their role is really to help patients transition from inpatient medical care into long-term suitability at their home. So I'm really excited that he's coming in to talk about, how the implications of communication and all of those things are impacted, especially when the family is integrated in that support. So thanks for joining us, Sean. Why don't you kind of start and tell us like a little bit more about kind of what you guys do and a little bit more about yourself.
Excellent. Well, again, thank you for having me on the show in this podcast episode. So essentially I am, like I said, Sean with Mid-South Transitions Medical Group. We've been established for well over 4 years. Doesn't seem like a lot of time, but I have a healthcare background dating well over 3 decades, mainly in the pharmacy world. But we've established this practice over 4 years ago, and we focus on the patient who has a high risk to readmit to hospitals, especially the frequent flyers going through the ER. Those are very sick patients. Usually, they have a lot of needs. They don't have a lot of great communication and many different references, but we help fill the gaps. That was the reason versus missional move that we wanted to create the practice in the first place. The practice is not just a typical doctor's office. We focus on house calls, traditional house calls, medical house calls for sure, and telemedicine. We utilize the technology we now have, access to fingertips, even in the rural areas, and we increase that access to care literally 24/7, 365 with the type of care that we provide. In the sense that, in comparison, transitional medicine in the past, say 10 years, has been evolving from insurance companies, Medicare, things like that, to have more compliance-driven, better outcomes. And that's where they give you interesting metrics to meet, and they don't always tell you how to get there. And so we've felt that we should step into that game. Myself and my 5 other business partners, I have 3 physicians, our owners, 1 nurse practitioner, a pharmacist, and myself. And we have that in the whole capacity. We now employ over 60 nurse practitioners in less than 4 years, from no charts, 0 at the beginning. And we operate, and we're based out of Texarkana, Texas, but we have multiple offices in Tyler, Texas, Jonesboro, Arkansas, Little Rock, Arkansas. We're even serving as far as Dallas, Fort Worth. So we're literally the main Mid-South when we created it. We created for the Mid-South United States as a missional move, once again, to help increase the access to care and solve a lot of those problems with the gaps of family members, all the way through to even the caregivers. We all have different levels of gaps that we must cover in order to optimize the patient's outcomes.
Absolutely. And I would imagine that's a very nerve-wracking time for a patient that's going from an inpatient setting to now, okay, I don't have the nurse, the team, the machines, all of those things around me. They were often probably, I'm sure, incredibly nervous. Family members are nervous. How do you ensure that patients, really kind of stay compliant as they are moving into more of their care at home?
Gotcha. So in this case, the type of practice we are, think of it definitely like a brand new specialty that didn't exist even 10 years ago. As much as, like, say, cardiology, gastroenterology are in commonplace these days and times, and has been historically for some time. Anyway, so what we do is we help coordinate the care. We're not acting like a social worker, but we are kind of in one respect, but we're doing it on the provider level. And so what we do is in the house calls telemedicine space, we execute many aspects at once, including not only care coordination, care execution, obviously treating patients according to providers and to it. We have other facets within the practice, and this is kind of where it gets to be a really cool deep dive, is we have a clinical pharmacy team, which I'm one of the big members there, and we help focus on the medications. And there's a huge amount of gaps in medicine, making sure there's compliance, making sure there's not duplications of therapies, overdoses of certain same drugs in the same class. There's huge disconnect. And it is really its own pandemic. And that's a big issue on top of the one we've all lived through and still getting a good bite from. So those things are very key. And we have not only the clinical pharmacy team inside the practice that is under the directive the provider saying, okay, go do your thing, go do your service, do your license for it, what you can do. We also have dietitian nutritionists that do the same thing under the direction of the provider. So it's a very big village to treat a patient. You have multifacets, multidisciplines, like what you would do, say, if you're going through a graduate school and in the doctorate programs and so forth. You round with physicians in the hospitals and nurses and pharmacists. They do that as well. They work as a team to take care of that patient they're seeing there. Even though they're in training and getting through the metrics and the ends of schools, it's very important at principle for that to continue in private practice or in the serving the patients, whether it be in a facility-based, a long-term care facility, a nursing facility, even at the normal, what we call nursing home. But really, even in patient's home, that's even bigger because there's a lot more dynamics, a lot more obstacles. There's just so much you can try to cram into that. And we try to solve that problem during the phase of transition from the acute care facility, i.e. hospital, back to their home or where their residence is, to make a new normal for them.
Yeah. So how, understanding that and your entire team is helping to be able to do that in multi-facets, which means probably a lot of information and a newer perspective on how to work with patients and help with patients. And then also a lot of times, even on a patient side, it's not just them. Usually they do have kind of a little support team or family that's helping. How do you, recognizing it's a newer space, how do you ensure kind of communication about either changes or about new perceptions in medication? How do you ensure that patients and their families best understand some of the information that you guys are providing? Because it sounds like it's pretty robust, which is awesome, but also a lot of different specialties.
Yes. So like you said, on the degree of communication, we have a lot of access, and a lot of people have needs when they say let's say they go from the hospital back to their primary residence. Yeah. For instance, then they have the discharge planners at the hospital. They've got to find out if they need home health, if they need specific duties or respiratory therapy at the house. And those are fine to do that, but coordinating care and then actually getting it all to be more symphonic in the way it happens for the patient at the time of the treatments or the services rendered, that's where the gaps come in. And so what people like Mid-South do, or what we do, I should say, is we kind of oversee the care. We don't replace any provider in the patient may or may not have. We do not do that at all. Specialists, whatever. We're there to cover gaps, and we're at the same time protecting their compliances that the other providers they may have, and basically you protect them to make sure that they're compliant there and backs up that whole group of compliance. It really just gels together. Oh, there we go. My screen timed out on me. I'm sorry. Saying a Medicare patient, Medicare says, okay, if you have a readmission to a hospital and it's with a certain criteria, all cause, partial cause, in a certain time frame with the same diagnoses that go back, they're not going to pay for it, and that facility is going to get dinged. Right. Well, we help protect the interest in that capacity, but that's not the prime focus. The prime focus is making sure the patient has these gaps covered. And we coordinate with home health agencies. We don't replace them. We're not a home health agency. We just work together with all these different players. That village is treating the patient, and it's actually simple, but it sounds vastly complex. But it's a lot of effort, a lot of communication, interfacing with different systems like EHRs, and then of course, where's your focus? There's your patient. You got to take care of them first.
Right. So yeah, and so with that, one of the things I remember when we were talking the first time we met is that I thought it was really key that you were really also saying, you just said it just now, is like at the end of the day, we're all really, really focused on the patient. And the more that we work on like developing those relationships with patients, making sure that they are in the more that our team can better support that. So talk to me a little bit about that. How do you go about that? How do you communicate that with patients and their families? Where's your mindset in that capacity?
I got you. I'll dive in on the medication specifics if we can for a second. Now, in my arena, again, being a medication and in pharmacy over well over 30 years, done in everything there is basically you can do in pharmacy. There's this latest thing that's coming around called pharmacogenomics. It's It's a one and done type of test that will test genetics, your genetics, like a swab, like the 22andMe, in some similar concept. And you can swab your cheek and have it analyzed, and it'll tell you what drugs in certain classes that you do need by your provider authority and treatment, but it will tell you which ones will minimize, say, side effects, would be more optimized for you metabolically. Now that is like super cool.
Yeah.
And even Medicare,
Very cool.
yeah, and Medicare and other insurance companies allow that for certain majority of the major classes of drugs. For a lot of the standard American treatments are being done, diabetes, cardiovascular type drugs. So you have this allowance, this little tool, one and done. It's not a big series of tests, but that is a great tool that improves communication from the providers, so they can, treat the patient in their little village, but also that can give the patient less confusion. Why do I have to take all these meds? They get overloaded with all the meds. Yeah. And so that little test can facilitate the communication from provider level and shrink that gap of communication, and then take it right down to the patient. And then really, hey, I don't have to take this extra pill or two, or this one might work better for me. I finally get it. Now it makes sense why I had these side effects. Yeah. So that closes the loop. And then when you have that engagement with the patient, they only, not only do you develop a great relationship and a bond and a trust, you just made their world a little bit better.
Yeah, absolutely. Well, and it's interesting you talk about even having that as a tool, so that the patient better understands, like, hey, this is what it is. This is what it's saying. This is why we're changing something, especially if someone's been on a medication for a really long time. I could see being a little resistant, like, oh, wait, no, you can't take that. I've been on that for 15 years. But right. The other thing that you said I thought was interesting is it allows you guys to communicate provider to pharmacist, and that place a lot easier to kind of be on the same page for how you're taking care of that patient.
That's right. And you always want to have that dialogue, because pharmacists go to school to be drug experts, pretty much. Doctors go to school to be medical experts in treating patients. And if you have these hybrided specialties in one locale, so to speak, then you have a bit greater chance of a return for that patient. That's just the bottom line. And at the same time, you save the systems, insurances and stuff over time. Tons of funds they don't have to pay out for other potential events, other worsening conditions, diagnoses, other undiscovered you never know how far that intervention will take and make something better, or eradicate something that could be costly in all kinds of capacities later. So that's why this model is extremely important. It's the way not only that the insurance companies are seeing it in a way, but they're also wanting to say, okay, you're gonna have to do this, but they don't tell you how to get there. And so when we figured this out, I'm not saying we're the only ones doing it in the United States, but we really put that with the missional mindset, with the depth, and we just said, we're gonna go. And we did it, and it's the effectiveness, the outcomes that are, the metrics do show, and about the proof of concept way beyond that. It's just that effective. And so that snippet that we've pretty much started to dive in here today is where you're going to see a major shift and change in the whole healthcare paradigm, because the current system is so fractured and broken. We all know it. But there's other technologies, other tools that we can all use to drive that compliance. Not that we're forcing it down somebody's throat, just to try to be more congruent in the way the outcomes are going to be. How would it take us to get to the outcomes over that village and these different things? It's really cool stuff.
Well, and it's interesting because it actually makes me think about, one, Medical Memory is a HIPAA compliant app that video records information that for patients or whatnot. But it's interesting because it makes me think of one of our doctors that started doing the discharge medication via video, because he's like, I can't get to each one of these patients. So I'm at least going to give this custom discharge instruction via video so that the patient has access to it. But even what you're even kind of saying is, even if you take kind of some of that information isn't just useful for the patient, it'd be useful for other providers to be able to watch or see, or too, where you could not necessarily do you have to do a house call, as you said, but maybe explaining, hey, this is the test, these are the things, these are what we're seeing, these are some things that you may want to do different, having even a recording of that the patient could access. But then some of these other provider teams could see what you as a specialist are seeing as it relates to them in the body. I mean, outside of using, and I'm not even sure if you guys use video, but that's one way I'm even like thinking in my mind. I'm like, man, those videos could even be, for the one pharmacist that's doing them to patients, could be useful cross-functionally. But outside of like, I mean, how do you guys communicate? Obviously, you're not always in a room all together with every patient.
Right.
How do you guys communicate effectively about a patient together? And do you use video? Have you ever thought about kind of that capacity? What are your kind of thoughts even in that?
Yeah, in our current EHR, they have a telemedicine platform that utilizes like what we were doing on a chat like this, or in the same as Medical Minute was doing. So there's ways to do it. It's a matter of making sure for the providers that software or platform is compatible with their EHR. Yeah. That's a big issue I've seen since we opened the practice 4 years ago. And then, if it works and it's still patient friendly, the stuff we see on the provider or the business side of it, it is not necessarily patient centric. And that I think is where the value and what you were talking about will come out, because it's more patient centered, but then the providers can see the simplicity of this and deduce and then have follow the paper trail, so to speak, and then make that continuity of care a lot better in outcome. And that's very important, very important. That's really the whole purpose in itself, along the road of treating the patient. You have to have the data, you have to have the facts, and so you can make a best decision if you are the provider or the non-physician provider or the specialist, whomever it may be. But if you don't have these ingredients, you just increase risk and potential for adversity, and you don't want that.
For sure. And that's why I think sometimes, live, like a telemedicine is a lot of times live back and forth, like we're talking now, whereas a recording seems to always be helpful, because not only the patient can rewatch it, but their family members can rewatch it, or anyone kind of in that bubble could be like, did I miss something? Am I understanding this right? And be able to have kind of that resource to help themselves be compliant. Especially as things are changing from the things they always used to do, too.
Exactly.
So, wait, sorry, go ahead.
I agree that utilization of technology is awesome. It will change lives, literally.
Right. I agree. So that also being said, I mean, one of the other things that you did talk a little bit about is not only just taking the time to build that relationship with the patient and answering kind of the questions, but also kind of transitioning them to feel more empowered and more involved in their own care, or their family also empowered and involved, especially when you're transitioning kind of in that space. Talk to me a little bit about that, or how do you teach your nurse practitioners to kind of help a patient transition in the way that they're thinking with that?
Well, you first find some good ones with a good spirit, and you hire them well. But no, we don't try to, we give them guideposts, kind of like boundaries. Like if you're on the road and, little markers, and we say, okay, if you have the right spirit about yourself, which we do, we screen them in our hiring process, for example. But we make sure that's first part of your foundations. And then you do what you were trained to go do, but make sure you think of it in a missional move sense. The patient is the mission, and the mission's never going to be done, but you need to remember who you serve. And it's not a command. We're not going to pound their head up or anything like that. We're just saying, just remember who we serve. We can't forget that. It's just out of the question. You have to remember it. Yeah. And then on top of that, and the other ingredients, we give the tools, like for having, say, a pharmacist do clinical medication therapy managements that back up the provider and what they are doing, and we're shepherding, overwatching those events. God bless you. So it's kind of cool how you can make them look like, in a sense, rock stars. Not that they don't already rock stars. You just make them shine brighter. With that aspect of that. And then that, of course, you can take the time with the provider and show them the ingredients, and they're like, whoa, how cool is that? And then, even to the big C-suite folks, if you show them the numbers, if you build it, they will come. The numbers will come, and you'll see in the revenue side, which is a whole deeper dive, probably another conversation. Yeah. But it all works together synergistically, but you got to remember who you serve. And the first is the patient, as we've said so many times here. I just can't say it enough, honestly, because it's the truth. But if we just all did this stuff in unison, which we do, and I mean, it's never 100%, but you definitely aim for the 100% always. Yeah. And when that dynamic works, it's on fire, and it just goes insane. And it's a good insane in this day and state. So hopefully that was helpful.
Yeah. Well, and you're really talking to it as far as like really looking at the people that you hire that have, you know, that energy or that servant's heart or things along those lines, because I definitely recognize and also like being a tool when we're integrating into hospitals, you know, a lot of times, and so now I have a question for you about that is sometimes people are like, oh, there's another thing. Oh, like there's more to kind of do. And even though they know in their core, you know, this is what's best for the patient, this is what's best for their family. I know it will help them heal. I know it will help them better understand their care, but they do feel overburdened or overstretched or any of those things. You know, how do you, even as a leadership team, or maybe it's, you know, aligning that core value that you said from the beginning, you know, how do you help some of those nurses that might feel, especially now, overburdened, overwhelmed, to continue to do the little things that may take just a few minutes longer to serve and to educate kind of the patient? I mean, what advice do you give to other leaders trying to implement, or what do you even kind of tell some of these nurses?
Well, that brings me back to an interesting book I read a long time ago. It's 15 years ago, I think it was, but there was one sentence that stood out to me the most, and this may sum all that up to answer your question. It was there in Dallas-Fort Worth area for about 100 years. There's a car dealership family, literally a family of folks called Sewell Village. And the great grandson is named Carl Sewell. If he's still around with us, I'm not sure at this time. However, he wrote a book called Service from the Heart. And I didn't want to read it at the time. I was kind of told I had to, so I did. But there is one profound sense that made the whole book, and all that my naysaying of not wanting to read the books, I had a lot of other stuff to do. It totally like sold me in a sense. Not a car. It sold me on the passion for people, and you can kind of see it bleeding through the screen and on the audio. But he said, I'm not in the car business. I'm in the people business. I just happen to sell cars. So in essence, everyone, whatever we do for an occupation, we must remember we're in a people business. We just happen to do fill in the blank. And that blank is, okay, I'm now a hospital administrator, or, I'm a nurse or a doctor, fill in whatever the blank is. But you're in the people business, and you must remember that, going back to the core tenets. And then on the second side of that, this is outside Carl Sewell's book, is you reinforce that by the leadership, and you show them, and you shower them with love in a appropriate way. Go to gift cards or whatever, but you want to hear them have the input. If they see something that can improve the quality of the practice or what they're doing, don't let it be on a deaf ear, no blind eyes. Yeah. Listen, and then be receptive, and then discuss it. And at least they had a voice, whether or not it actually comes to fruition. But be really genuinely open as a leader or a business owner or whatever, and just do it. And you got to have that. And then you reinforce your core tenets. And then, okay, hey, I'm going to buy you a lunch today. You know, that's the way it's going to be. And maybe do that in surprise, sporadic things. We've done that many times too. And retention for employees is, oh my gosh, amazing. I can show you my Facebook posts, and I mean, my employees are posting this, not me. Yeah. Almost like, wow, I feel really honored. I'm like, dude, thank you for saying that. That's really cool of you. But that value add has its own degrees of continuity, and then they pay it forward, and they're your best marketing tool or whatever. It's not. It's just, you have an organization that's doing it for all the right reasons.
Right. Well, it's interesting because that even ties into what you said at the very, very beginning. Like it takes a village. It takes, that integration. It takes everybody on board to take care of these patients. And just as you said, you're like, I'm not saying it takes, leadership or a few nurses, like, all a village. I'm saying everybody, and that, if your teams are feeling empowered to have a voice, to have ideas, to try new things, they're as much in that village in supporting patient care. And I think you kind of said that at the beginning, and that kind of like wraps it up kind of on how that even goes. in that mindset and that kind of core value of saying, we'll listen to your ideas too, or just let's try it. Let's try things, and always put patient centered first.
Absolutely, it's core, like you said. Yeah, absolutely.
That's great. Well, Sean, you are such a pleasure to chat with, and I really appreciate your time and your wisdom, and I really think that you guys are doing a lot of cool things, as you said, that's a little bit different, a little bit more innovative, to really kind of support what I would think is a hard time for a lot of patients. So I look forward to many more chats, kind of as we were continuing to evolve with your business, and as we're looking at patient communication. And thanks again for hopping on.
Absolutely. Again, Julie, appreciate the time, and I would look forward to and love to do more of these things.
Awesome. Thank you.
Bet, no problem.